Here you are watching drug-induced sleep endoscopy with BIS monitoring in a 51-year-old male with history of uh, daytime sleepiness, tiredness, and snoring, occasional choking. You can see he's got a deviated septum on the right side, which is blocking his nasal valve on the right, turbinate hypertrophy on the left. Sinuses also are little congested on the CT scan. He has a postnasal drip issue at times. His body mass index is 28, which is obviously not very high, and his muscular is not obese, not fatty. And his AHI on the sleep study is 16, most of which are obstructive hypopneas, not apneas. As we go inside, there is no adenoid. The salpingopharyngeal folds are also, I would wait for the BIS to come down so that I can understand what exactly is happening to the salpingopharyngeal folds. But as of now, they do not look quite hypertrophied. I'm still waiting for the BIS to come in the correct range, but meanwhile, I'll just go and have a look at the base tongue. Base tongue is not large on the CT scan, and we do not see any base tongue collapse here. His palate was long on the clinical examination and on the CT scan, and the same thing we see here as well. And it's a funnel shaped collapse. You can see the upper part of the soft palate is not collapsing. The velum is fine in the upper part. It's only collapsing in the lower part, so it's a funnel shaped collapse. And you can see this is the uvula, and you can see the base of the uvula going behind. You can see the both AP as well as lateral collapse. This is now in the correct range 70s, and we only see a palatal collapse. Alright. So as we understand, he has majorly hypopneas, which is mostly because of the nose, partly because of the throat. So if we want to only tackle the daytime sleepiness, then first thing would be to do nose surgery. If we also want to tackle the snoring part, then we may do suspension bridge pharyngoplasty in addition to the nose surgery. Can you see? That's the uvula. Uvula is not, the tip of the uvula is not collapsing, and it's only the base of the uvula which is going behind. Can you see that? Very clearly seen in this case. It's the base of the uvula which is creating the collapse. So if you decide to do anything to the tip of the uvula, it will not work. You have to work on the base of the uvula, and that's, you can do a uvulopalatopexy or you can do a suspension bridge pharyngoplasty. It's the base of the uvula which is important, so that part has to be taken care of. So once again, I am trying to go and have a look at the tongue base and the epiglottis, which are not really collapsing, just a partial collapse, not a complete collapse. Complete collapse is only of the soft palate, majorly anteroposterior, partly also lateral. The salpingopharyngeal folds are grade 0. I would not really uh, score them very high. Turbinate hypertrophy on the left, and as I said earlier, a little large middle turbinate, and he has got congestion in the sinuses on the CT scan. That has to be tackled. Most important thing is the high deviated septum, especially in the anterior part. Can you see? This is the most important thing which has to be corrected. So if you do not do the high part of the septum, then the septoplasty is not going to work at all, because it's only the high part of the septum which is blocking the nasal valve on the right side. This is the most important thing along with the turbinates. Thank you for watching.